Hello, everyone. Welcome to our webinar today on SSRIs in clinical practice. It's my pleasure to introduce our speaker for today. Dr. Ryan Rampersaud is a child and adolescent psychiatrist in the Division of Child and Adolescent Psychiatry here at UCSF and the Department of Psychiatry and Behavioral Sciences. Dr. Rampersaud completed his MD and PhD in microbiology and immunology at Columbia University and his psychiatry residency and Child and Adolescent Fellowship at UCSF. His research program focuses on the role of the gut microbiome in the development of psychiatric disorders, including mood disorders, and understanding the biological mechanisms by which early life adversity affects physical and mental health. As I mentioned earlier, Dr. Rampersaud will be speaking about SSRIs in pediatric clinical practice today. As questions come up, please feel free to type them into the Q&A section of our Zoom meeting today. We'll be reserving the last 10 minutes or so for live Q&A. With that, I'll hand over the virtual mic to Dr. Rampersaud.
Thank you so much. So excited to talk to you all today about SSRIs in clinical practice. No disclosures. Next slide. So today, main points are we want to be able to talk about 3 commonly used SSRIs, including usual, initial, and target dosing. Can you all hear me okay? Okay. Additionally, we want to be able to have a conversation about SSRI risks, including common side effects, risk of activation, and then also leave you with some language pearls so you have some guidance in terms of talking to patients about benefits, risks, and side effects of medication. Next slide. And you can hit next again. Okay, so SSRIs. So these are medications that are thought to sort of target the serotonergic system. And so essentially, the underlying idea for a very long time has been that depression and mood disorders are a symptom of low serotonin. And these SSRIs, selective serotonin reuptake inhibitors, block presynaptic serotonin reuptake to treat depressive and anxiety symptoms. We know more now that it's not quite that simple, and we're starting to learn more and more about exactly how these things work. But as we'll talk about today, these medications are really efficacious and can be extremely helpful for our patients. Next slide. And so just wanted to take a look at the sort of prescribing trends over the past several years. So the main point here is that over time, as things have gotten, as the mental health crisis has gotten worse, prescribing has continued to increase. And I'm sure if we had post-pandemic here, we would see that bar jump even further. And so these are important things, important medications for us to have in our arsenal and to be able to deploy given what we're seeing in our daily practices. Next slide. And then this is just sort of reiteration of what I've already said, which is that prescribing has increased significantly, and it's across a variety of countries. And again, just to highlight the point that this is a real burden, and all of you are the ones who are seeing this in their daily practice. And so we want to give you a little bit of guidance to help you begin to utilize these medications in your practices. Next slide. So just a little definition. When we think about treatment, we think about 3 phases: the acute phase, the continuation phase, and the maintenance phase. The acute phase is where we want to start a medication and achieve a response and ultimately symptomatic remission. In the continuation phase, we want to consolidate that response to treatment and avoid relapses. And as we'll talk about in a little bit, that includes SSRIs, but also other interventions, whether that's behavioral, psychotherapy, or other things that you implement with families to kind of continue to keep that response going. And then a maintenance, we want to avoid recurrences and new episodes. And so you have a little bit of a definition on the side there. A response is a significant reduction in symptoms for at least 2 weeks. And remission is the same, but it's between 2 weeks to 2 months with no or very few symptoms. And then recovery is an absence of significant symptoms for about 2 months. In terms of the length of time that you treat people, we'll talk a little bit about that at the end, but it's sometimes helpful to have a conversation with families about the sort of trajectory of what things will look like. And I think that these definitions And talking about these phases of treatment can help ground families so that they understand what's happening and it doesn't feel sort of lost. Next slide. So when we're thinking about anxiety and depression, which is the main indication for these antidepressants, always want to be ruling out medical causes. And so here you have a whole list. I won't go through this, but you'll have slides available. And it's just important to be thinking about these things and to be inquiring about some of these potential medical mimics for, in this case, anxiety. Next slide. And here it's sort of depression. And so you can see there are some commonalities between the two, and then there are some specific ones here, medical causes of depression that, again, you want to rule out as you're doing your diagnostic evaluation of the patients who are coming in to see you. Next slide. Screens and tools. So I really like to talk about screens and tools because I use them constantly. And the truth is that they help me make decisions about what it is that I'm going to do. And so want to encourage people, and we have these all available on our website, easy access, to be sort of utilizing these things to screen and then also help you make decisions about whether or not you're going to start a medication. And so for anxiety, we have the GAD-7 and the SCARED. The SCARED, I think, is great, especially for some of our young kids, because there is a parent component to it. And we often want to have both patient input about what's happening, but also independent observation from families. For depression, I'm sure you're all very familiar with the PHQ-2, the PHQ-9, and then the short mood and feelings questionnaire. PHQ-9s are great for a range of kids, especially our adolescents, but the short mood and feelings questionnaire can be helpful for slightly younger kids. The ARCADS is a little bit longer and less easy to use in a sort of 15-minute visit, but it is available again, for screening for both anxiety and depression. And so would encourage, liberal use of this, because again, I have to say I use these things regularly when I'm seeing patients. Next slide. So general guidelines, and we'll jump into sort of dive into each of these components. But when we're thinking about SSRIs and thinking about starting them and thinking about choice, it can feel sort of dizzying with the number of antidepressants that are available. Which one should I choose? Which one is best, I think, is a question that comes up sometimes. And the main point that I want to make here is that SSRI efficacy is similar. There's no evidence to say that one is better than another. And really what ends up happening is we choose based on a person's past history response, sometimes family history response, side effect profile, and coexisting medical conditions. We're going to jump into this in a little bit more detail, but just keep that in mind, that a parent may come to you and say, which one is best for my child? And I often will say, listen, we have to sort of think about the whole picture here before we make a decision. But whatever choice we make, the efficacy can be potentially similar between all of them. Now, the other question comes up, how long is this going to take? Am I going to feel better tomorrow? And unfortunately, these are not stimulants. And so their mechanism of action is a little bit different. And so we often say, just to give families a little bit of an expectation is, listen, between 3 to 6 weeks is when 3 to 6 weeks after achieving a therapeutic dose, you may begin to see some symptom improvement. Some remission may be seen by week 4. And so how long do I have to wait until I know that something is working? When should I make a change? When's the appropriate time? Really, I think 6 to 8 weeks, and 8 weeks really, if there's no improvement after 8 weeks at an adequate dose, we can either switch to another antidepressant or augment with another agent. And we'll talk a little bit about that. Interestingly, studies have demonstrated that SSRIs have better efficacy or more benefit for anxiety disorders than depression, and especially in younger children. And so I think sometimes we may be concerned about starting something like this in a kid with anxiety or in a younger child, but they can be efficacious when they are indicated. And we'll talk a little bit about that. Next slide. I won't go through this, but this is several of the studies that have looked at the efficacy of psychotherapy plus antidepressants, or antidepressants or psychotherapy alone. And I think the main point here, as you can see from that first really big study, the TAD study, this was really critical, and demonstrated that really the combination of the two was the most superior, to just antidepressant alone or CBT alone. And now sometimes we don't have access to CBT, or we don't have access to psychotherapy. And so you can see sometimes in those cases, Prozac, or antidepressants, SSRIs, may be particularly useful if you don't have access. But really, we want to try to find a combination of the two to help our patients. And then below that are a couple of other studies, and they basically say the same point that I just made. Next slide. And then here's another listing of all of the studies that have looked at anxiety. And the main point here is that SSRIs are particularly useful, and you can sort of look these up if you're interested in the numbers and details. Next slide. So, in thinking about what happens when when a patient comes in to see you, the GLAD PC toolkit, and I think that you've already heard about this, for screening for depression, I think is a great framework for thinking about the phases of my treatment with somebody. I get a new patient, they come in, I really need to screen them. And that's where my screening tool comes in. I make a diagnosis based on those screening tools and independent observations. And then we think about initial treatment, maintenance treatment, and management. And so we'll kind of go through those phases. We've already talked a little bit about screening and diagnosis, using those tools, ruling out medical mimics, and really getting an independent information from families about what the symptoms that may be presenting themselves. And so in the next couple of slides after this, we'll talk a little bit about treatment. So let's go to the next slide. And so this is kind of what I was suggesting before. So you can see on the left-hand side, clinical judgment trumps everything, right? You are the person who is seeing that patient. You may have a long-term relationship with that person and know them very well. And so I want to sort of just remind people that their clinical judgment and intuition makes a difference, and to listen to that while they're making decisions. But screening tools have been very helpful. And so you can see, when we think about depression, for example, we sort of break people up into mild, moderate, and severe. Mild being a PHQ-9 of 5 to 9, moderate being a PHQ-9 of 10 to 19, and severe being a PHQ-9 of 20 to 27. And you can see there are some other things in here, including impairment in functional domains and or co-occurring conditions that might also help you decide that this is a patient who would benefit from starting an SSRI. And in the next slide, we'll talk a little bit about how you use mild, moderate, and severe to make a decision about treatment. So next slide. And just before we get into that, we wanted to put this in to talk about the biopsychosocial model, because we use these scales, but there are all of these other environmental factors, right? There's biological, so maybe there's a family history, other medical problems, medical trauma that we will need to incorporate into our diagnostic thinking. There are social and cultural factors. Maybe there's some family discord. Maybe there are, there's a history of trauma. There's racism, bullying. All of these things need to be sort of factored in. And really, we're sort of living in that place where all of these factors come in, and we have to kind of take them all into account when we're making our diagnosis. And our treatment plans have to incorporate all of that. Next slide. And so how do you get started? Now we're into the action. So, we've done our screening. We said, I think this person has a depressive disorder. They're impaired in a variety of ways. And so, maybe I did my PHQ-9 and they sort of fell into that mild depression. Well, I think that's a place where we could say, listen, let's do an active monitoring for 6 to 8 weeks. And what's important during this phase is to really set and monitor treatment goals. So I think one of the things that sometimes happens is when it falls into this sort of mild depression, it's easy to sort of have them move on. But one of the things that's really important is to partner with families and say, these are the things we're looking out for. If these things are getting worse, I'm not taking care of my body, I'm not engaging, I'm not eating, I'm not sleeping properly, then we need to really think about those, escalating treatment. But setting that expectation for monitoring at the outset is really, really critical. We also want to have some wellness goals because we know that eating and sleeping and exercise all affect our mood. And so it's really great, I think, to sort of have a conversation about let's make sure that our sleep is on point. Let's get rid of, distractions. Please no phones, please no gaming systems. Let's talk about exercise. And maybe it's a family exercise thing. Maybe we all say, listen, after dinner, we're all going to go take a walk around the block, right? Leverage that family connection to sort of build in a little bit more of those wellness goals and what I might call behavioral activation. We want to collaborate. Families are our eyes and ears. We're not with people all the time. We have to partner with families. They are the people who are going to feed us the information that we need to make informed decisions about next steps. And because children and adolescents can be impulsive, we always want to be thinking about safety planning. And this is really, really critical. Now, if you have a kid who's moderate to severe, or if they had mild depression and they didn't quite improve with just some of these wellness goals and further family support, then we might think about more immediate treatment. That's the point at which we might think about SSRIs, an SSRI intervention, in addition to psychotherapy, if possible. And we tend towards liking evidence-based therapies. And so if you go to the next slide, and you can see that for MDD, we have lots of different kinds of therapies: CBT, IPTA, problem solving, interpersonal problems. These you may ask. I think you can encourage families to ask for a particular type of therapy. I will say that in some cases, in some areas, that may not be available, and we have to be realistic about what is available. And so sometimes just having somebody, any kind of therapy is helpful. But if we can get evidence-based therapy, that really is the gold standard. And now with online delivery of therapy and telehealth, I think that's much more accessible. And you might also think about some groups. So let's go to the next slide. And we can sort of skip this slide altogether because it just kind of says the same thing. And again, skip this. And one more forward. And again. Okay, so now when to prescribe. These are, again, your clinical judgment comes into play here. You are the experts, you know these families, but here are some sort of guiding principles when it might be really simple and the barrier might be low to prescribing. One, a mild, uncomplicated mild anxiety that progresses to moderate. Two, if you see a kid that has significant impairment, I'm not going to school, I'm not eating, I'm not bathing, I'm not participating in activities that I used to, that might be an indicator to you that it's time to start something because we're sort of have moved off of our baseline. Failed or partial response to therapy and active support. So maybe you saw your kid and they started off in a sort of mild range and they did do therapy, but it just didn't quite take, they weren't able to sort of progress and get out of that phase. And why that is sort of multifactorial, but that might be a place where you tell parents, listen, I think we've tried, and I think they may need a little bit of a boost here. And it doesn't have to be a forever thing, which is something I remind people. The other point down here is parent and patient agree, after education on medication risks and benefits. We have to be realistic. Sometimes families are not quite ready. Cultural reasons, social reasons, maybe they've had bad experiences in the past, and we have to meet people where they are. And so I think that this is a long game sometimes. And in my own practice, sometimes it takes, several visits, and we have to build a relationship with people. And so give yourself a little bit of grace here. If they don't jump at the first visit to start a medication, you can monitor and watch. The other factor here is, do you know the patient? Are you able to monitor? Is this a patient who just showed up to your practice? Honestly, in my practice, if I don't know you, I might wait and say, let's have a couple more visits so I get to know who you are. Are the parents reliable? Is the kid even interested? And do I fully understand kind of what is happening in terms of the depression or anxiety that's presenting itself? And then again, can you consult and collaborate with others? And luckily, you can call us anytime. We'd love to have a conversation about it. Give us a call. We'll just talk. No big deal. Next slide. And so this just kind of says what I said before. And really, main point is use that guiding, use those screening tools. Mild, watch and wait, active monitoring, moderate to severe, or really significant impairment in functioning or significant persistent suicidality, think about initiating a medication in addition to psychotherapy treatment. Next slide. So, where do we start? Can you go to the next slide, actually? I think, yeah, here we go. This is the one I wanted. So we've seen a kid, we've decided parents are caregivers are on board, they want to start something. Where do you start? And so again, it can seem somewhat confusing about which one to choose. And so we'll just go through very quickly a couple of the choices here. So Prozac, I think is probably the one people are most familiar with. Lots of evidence and FDA approval for Prozac. One of the benefits of Prozac is that it has extremely long half-life. So if you have a kid, maybe they have comorbid ADHD, they can't quite keep track of their medications, maybe caregivers also have ADHD and can't quite keep track of the medications, and we tend to miss doses. This is a great choice because if you miss a dose, it's no big deal. You're not going to have any sort of uncomfortable feelings from missing that dose. It is also an SSRI. If you're worried about a kid who's abruptly stopping, it's an SSRI that you can just stop because it does sort of kind of trickle out of your system given the long half-life. The one thing to think about is that it can be more activating. And so sometimes if kids have a comorbid anxiety disorder, it can potentially worsen the anxiety. But I will say that that is not a hard and fast rule, and it shouldn't prevent you from prescribing Prozac, even though there's anxiety. Sertraline, or Zoloft is another one that you might have heard about, which may be somewhat sedating. And it has a mild dopamine blocking effect. I think when I think about Zoloft, I do think about my kids who maybe have a comorbid anxiety disorder, because it can be a little bit helpful for that. Maybe they're having some trouble with sleeping, and so sertraline Zoloft can be helpful. Luvox is one that we don't really use in this country. It's a UK thing, so I don't know if we have any UK visitors in our webinar today, but it's one that we tend not to use. Escitalopram or Lexapro and Celexa, which is a sort of version, tend to be more neutral and less activating. I think when I think about these two, I tend towards using these in my kids who have lots of medical comorbidities or in my kids who are being treated with a lot of medications. And so I have a number of kids who have co-occurring seizure disorders, and I tend to sort of think about Lexapro or Celexa because they're often on this sort of really complex cocktail of other medications. Paroxetine or Paxil is one of the sort of earlier SSRIs. It can be sedating. We tend not to use it anymore because of its risk for weight gain and the sedating effect, and it does have a lot of drug-drug interactions, but it's still there and available in the arsenal. It just tends to be one we don't use, just given how the significant association with weight gain. Next slide. So we've got our kid, he or she is ready to go, parents are on board. What do we do? First step is we've got to educate our families about the potential risks and the benefits and the side effects of these medications. We want to get consent from the guardian, but we also, especially for our older kids, want them to feel like they are partnering with us in this endeavor, and don't want them to feel like it's a punishment or something that they have to take or they're being forced to take. And so we often, we want to include our kids in those conversations, especially if they're older. When they're a little bit younger, they can't quite grasp that, and so the language you may use may be a little bit more vague. But we definitely want those adolescents to sort of say, yeah, I'm on board. I know that there's a problem. Always, always, always safety planning. And we'll talk a little bit about why that will be important in the initial stages of initiating an SSRI. And then let's set expectations for schedule of visits. I think personally that this is really helpful, not only for the family, but also for me. I feel much more at ease when I know that this is how we're going to see each other, because sometimes, you give somebody something and they sort of disappear, and it can be a little uncomfortable when they're just sort of out in the world living their lives. And so having that schedule sort of sets the expectation that I'm going to give this to you, but this requires our partnership together. So let's make sure that we continue to see each other. Next slide. So consent and an assent. So you can see this is just we are required to get consent from families, but again, it's important to have those kids really be on board and be informed about what it is that we're giving them, and to also acknowledge concerns, say, note that they are real concerns, and then answer questions, right? Our job here is to sort of alleviate anxieties about what may or may not happen, what fantasies people have about what happens when you take an SSRI, beliefs about what it means to take an antidepressant, and that can go a very, very long way. Next slide. So monitoring visits. So in the first month, when we're just starting, we may want to sort of monitor weekly. I always start low and go slow and increase every 2 to 4 weeks if there's no side effects. Monitoring weekly is a great idea in theory, and I think it's hard in practice. And so if there are ways to sort of do that monitoring, maybe you have staff who could just check in with the patient. Maybe it's just a quick email and the parents that you've collaborated with can sort of feedback information. Maybe it's a quick phone call. We know that the medical system is sort of overwhelmed, and so we have to sort of think about ways to make it realistic and feasible, but we do want them to feel like they're in charge and connected. In that second month, you may want to monitor every other week and then start to see a therapeutic effect within 3 to 5 weeks. These are all guidelines, by the way. So again, your knowledge and clinical judgment, if you have a patient who maybe is a little more high risk, you may say, I need to see you more frequently or check in. Or if you have a patient who has a family who is doing, is very on top of the ball and can communicate with you well, then maybe you start to space it out a little bit. But we do want to be kind of a little bit more mindful at that beginning. And then in the third month, when you've sort of reached a kind of steady state, we're monitoring for a year, monthly for a year. And again, that can also be stretched out depending on how things are going. You'll read that situation, but at the beginning, maybe you want to get more. I think more data points are better than fewer data points. And so you can kind of stretch that out. Again, you are the expert here. Next slide. And so talking to families about side effects. Okay, so this is the thing that gets everyone's concerned, and everyone thinks that everything is going to happen to them all at once. And I always have to remind people, I have to tell you about these side effects. That doesn't mean that all of them are going to appear in the day that you start the medication. But what are the major side effects? And really, I think this list here is sort of like most common to least common. And really, GI distress is the most common. Some kids have headaches. Some may see appetite change depending on the medication you choose. It may be overly sedating or overly activating if you chose Prozac. Sleep disturbance potentially. Some sweating, sexual side effects. I think sometimes we don't talk about it, but for our older kids, I think it will be important to really have that conversation and say, this is a possibility. We also want to think about activation. So some kids who start an antidepressant have this sort of uncomfortable feeling, and we'll talk about that in a minute. And then, excuse me, platelet dysfunction, which is extremely rare, but it has happened. And so you just want to monitor for like uncontrollable nosebleeds, things like that. I think the pearl here is to remind people that one, you are starting low and slow in an effort to mitigate the presentation of these symptoms, and that a lot of these symptoms are self-resolving. So for example, the GI distress, maybe the sleep disturbance or the sedation, these might be just self-limiting. And so if you can manage through like 1 to 2 weeks, you can set the expectation that a lot of them will disappear. And I think setting expectation is really huge for families. And I think that's something that we can offer them. I really think that it reduces anxiety. Next slide. So the other big side effect that we want to talk about is serotonin syndrome. again, my spiel is often, I have to talk to you about this, but it's not going to happen. Like, it's not the most common thing to happen. And it tends to be more of an issue if you have a bunch of other serotonergic medications on board as well. If you've got an uncomplicated kid who's not really taking anything, my concern about this is not super, super high, but we have to remind people. And so the other big thing that comes up is this neuroleptic malignant syndrome, which can happen with antipsychotics. And so you can sort of tell the difference by the temporal nature of it. Serotonin syndrome tends to happen within 24 hours, whereas NMS takes days to weeks. Serotonin syndrome has this sort of hyperreactivity and hyperreflexiveness with a tremor, and then increased temperature. Again, something to note, something to like let parents know about to see if they're seeing anything that seems kind of strange, but not a very common thing. Next slide. So why was that safety planning, bullet point at that very beginning when we're talking about it? We talked about education, we talked about consent. Why safety planning? Well, in 2004, the FDA issued a black box warning that said that all antidepressants have an increased risk of suicidal thoughts and behaviors in young people up to age 25. Interestingly, there were no actually increase in suicides in the studies, but there was increase in suicidal ideation. We bring this up, again, it's not the most common thing, but because of the significance and severity of it, it is, again, one of these things that we have to talk about. And I often just tell parents that I have to tell you about this because it's possible. But is it common? No. And really, that highest risk for emergent suicidality on an SSRI is within the first 9 days of treatment. And it's usually with a higher than usual starting dose. And remember, we're starting low, we're going slow. That's our guiding principle. Next slide. So I want to point out here, the numbers are really just for me. And but you can see MDD, OCD, and then non-OCD anxiety. The far right-hand column is the number needed to harm. So the number where you get increased suicidality and some adverse outcome. And the numbers are pretty high compared to the number needed to treat to see a benefit. And so it's always a risk-benefit analysis. We're always saying that, listen, the risk of undertreated or untreated depression or anxiety or OCD is much more significant than the potential for the emergence of this SSRI-induced suicidality. Next slide. Oh, there we go. Same thing. This was just sort of a meta-analysis of lots of studies. I couldn't help myself because I love a meta-analysis. But you can see that there's different effect size, risk ratios for different antidepressants and different studies. Really, the point is that it's not a huge number. Next slide. So what are some predictors? This is not, you can't predict. I don't have a crystal ball, but maybe this could help you sort of risk stratify a little bit. Maybe you think, okay, well, predictors of increased suicidality within 6 weeks after SSRI initiation include female sex, depression as an indicator, right? Previous suicidality and previous self-harm. I think that this study said something that you all kind of know to be true without having to do a study, which is if you've done it before, you're at higher risk for doing it again. And so you may, in certain cases, if you have a kid who has been harming or has had a previous suicide attempt, you may say, you know what, this is the kid I need to see a little bit more frequently or check in more frequently with. And you can see the papers down there if you're ever interested. Next slide. So I've often thought about like, what is the reason for people having increased suicidal thought? And it may be that their depression is actually improving a little bit. And so they have more energy, but they're still in that sort of dysphoric kind of state. It's possible that we've undertreated and the depression is just worsening. And it's just the natural history of the child's presentation, right? It's possible, and we'll talk about this in a second, that it's akathisia, this sort of uncomfortable feeling that can be really can really affect kids. Maybe it's anxiety. So maybe you started Prozac and you had a kid who had comorbid anxiety, and the anxiety kind of ramped up a little bit. It could be that there's a precipitation of a hypomanic or manic state. And again, not a super common thing, but it's something we'll talk about in a second. It's something to watch out for. Perhaps our antidepressant has caused some problem with insomnia or sleep, disturbance of the sleep architecture. And so we want to be you guys already asked about this, but just continue to ask even more. What's the sleep like? There may be some obsessional thoughts that maybe are presenting themselves that maybe we didn't see at the beginning. And then there's some biological or brain circuitry potential mechanisms that we're still sort of starting to understand. But I think the reason I put this up is that sometimes parents will ask and I will say, these are I don't know, but these are the potential options. And really what we can do is to keep a close eye on things. Next slide. So we talked about behavioral activation or akathisia. And so some kids, when they start an SSRI, have what I call ants in the pants kind of situation. It's really uncomfortable. They can't sit still. They're disinhibited. They kind of can seem manic. They may be sort of self-harming because they have this kind of uncontrollable, unsettled kind of feeling within themselves. In order to deal with that, right, you can assess adherence to the medication. So one, as we talked about, right, the natural history is sort of changing up and down. Was the kid even taking the medication, right? Maybe it's just that they didn't do it. If the activation is really bad, we can consider decreasing the dose. So going back to the last effective dose and holding and seeing how things go and seeing if the activation resolves itself. Or we could consider switching to another SSRI or stopping it altogether, giving everybody a breather, which is a totally appropriate response, and then reevaluating once we've sort of gotten past that, as long as there's no issue with sort of abrupt stopping. Next slide. So the question that often comes up is behavioral activation versus bipolar switching. I think it can be kind of a scary thing to think that you've precipitated a manic episode in a child. And just hit next once more so there we go. And so what's the difference? Really the difference here is about the temporal nature of these things. Behavioral activation occurs initial days and weeks after starting or increasing the dose, whereas a bipolar switch occurs later on in the treatment. So that's one piece that can help you determine whether or not there's a manic episode. The other big piece is a mood change. Behavioral activation, that kid is still dysphoric. They just feel unsettled and uncomfortable. In bipolar switching, the kid does have some mood changes. They've moved from a depressed state to maybe more irritable, more significantly manic, more hypomanic, up, elevated, super happy, and then, reduced need for sleep. And so those are some things. And so if you're ever concerned, right, we're always available. Give us a call, consult with another psychiatrist, and we can sort of talk through about what might be happening. Next slide. So the other big thing that I think comes up and want to talk about is how do we talk with parents? I think there's a lot of misconceptions, despite all of the big pushes to sort of reduce stigma about the use of antidepressants or about psychiatric medications and psychiatric diagnoses in general. I still think and see that it still happens, right? And that's for a number of reasons. And I think part of our responsibility and part of our job is to provide education to people so that they can make informed decisions. And so they're not, they're not basing their decisions off of myths or legends about what is happening. And so you can see a couple of examples, and I'm sure maybe you've all seen some of this. Will the medication make my child or teen feel like a zombie or change their personality? Are they going to be somebody different? And so when, we'll often say something like, when taking and titrating as prescribed, SSRIs don't change somebody. At high doses, they can have this kind of numbing effect potentially, but it's not a common thing. And so you can sort of have people who say, I feel numb, nothing makes me happy. And in that case, lowering the dose or augmenting with another medication or switching to a different antidepressant might be helpful. The other one is the black box warning, which we kind of talked about already. well, if it's going to make them suicidal, then maybe we shouldn't do medications at all. And we want to remind people that medications are a support. They're not necessarily a forever thing, right? We can have a conversation later on down the line about what we do with the medication. But really, the main point is that SSRI-induced suicidality is not a super common thing, and depression is really worth treating. The point of the medication is to feel better, not worse, and to remind parents that you're there to partner with them. So if they have a concern about something, if they notice that something is getting worse, tell me right away. Don't wait until the next visit. Reach out to us. We can always make a plan. Even if I can't see you that day, we can always make a plan of what to do. And I think that, and you could all back me up, I think, on this, is that just knowing that somebody is there to help guide them through the process can be particularly helpful. Next slide. So what if I've gotten my kid up to an adequate dose, I've maxed them out, and they're still not feeling better? Well, you could substitute the new SSRI at about the same dose of the former SSRI. So maybe you want to switch from, say, Prozac to Lexapro, or let's say Lexapro to Celexa, right? You could just do a quick switch, or you could start what we call cross tapering, which is starting the new SSRI at a lower dose while concurrently reducing the original SSRI. And so one goes up over time and one goes down over time. This is sort of where the art of medicine comes in, because there is no hard and fast, this is the titration schedule, and you're going to be responding to what's happening for the kid. Are they tolerating things? And if you're doing Prozac, because of the long half-life, you want to DC Prozac for about a week and then start the new SSRI at a lower equivalent dose. So if you go to the next slide, we have here on the right-hand side. So on the left-hand side, you can see like the approximate half-lives of the antidepressants. They're basically all the same, except for Prozac, which has that really, really long half-life. But on the right-hand side, this is something that I use personally to sort of help me figure out what I'm doing. And they're SSRI dose equivalent. So you can see 20 milligrams of Prozac is about the same as 10 milligrams of escitalopram, which is about 50 milligrams of sertraline. So you could, in theory, like let's say, I had somebody who was on 50 of sertraline, I could say just stop sertraline and start Prozac at 20. And I'm getting about the same dose. We prefer to do a cross taper where we sort of reduce one slowly and increase the other one further. And if you give us a call, we've done this before. I love to just give a very long, detailed titration schedule for people. And so we can have a conversation about that. And so if you're ever concerned or worried about how to do it, just give us a call. Next slide. And so we always want to think about, especially for some of our kids who are prone to abruptly discontinuing their medication because they came home one day and they decided they didn't like it, or they saw a YouTube video or a TikTok or something about SSRIs and decided that they weren't going to do it anymore. And we want to counsel our kids on the fact that SSRI discontinuation syndrome is a real thing. Please don't stop the medication. I'm not going to force you to be on a medicine, but I will help you figure out, if there's a right medication for you. And if you want to come off, I'm going to help you do it in an appropriate way. Sometimes we want to be like reducing the dose slowly over time. And again, we want to partner with people, but remind them that SSRI discontinuation syndrome is a real thing, and it's characterized by flu-like symptoms, insomnia, nausea, imbalance, sensory disturbances, and then hyperarousal. It is not life-threatening, and I remind people of that because I've had kids in the past who were worried that something really, really bad would happen, but it is particularly uncomfortable. Next slide. And then this is just another study that talked about all of the discontinuation signs and symptoms. And really the main point is that these are really uncomfortable things and nobody should have to experience this. So partner with me. I'm going to help you figure out how to get to the end. I'm never going to force you to be on something, but I want to be your partner in this. Next slide. So how long does the treatment last? I always tell people, listen, if you needed the medication, let's go for a year and then we'll reconsider. I have lots of kids that I've taken off SSRIs because they were able to get therapy and they managed through and they figured out their depression or they got through the anxiety. And then maybe they continued their therapy and that was sufficient to hold them. But you have to consider multiple factors. And I tell my kids this all the time. There may be particular environmental things that are coming up that maybe we might want to consider going past that 1 year. Maybe you haven't reached full remission and we're still figuring things out. That's okay. It's not a failure. We've just got to we've got to keep trucking along to figure out what to do. Maybe you have gotten better, but there's a big impending change in your life. I had a kid who was going away to college. She had done really, really great after a year on an SSRI at an adequate dose, but she was going away to college. And in the past, big changes to environment had caused a lot of instability. And I said, I really think you should consider continuing on this for another couple of months while you get settled in college. And she agreed, and she ended up doing fantastically in college. And she agreed that part of it was sort of having that base underneath her. And then we took off the medication eventually. So consider that with your kids and also remind them that it's possible that they may get off of it and life will happen and they may become destabilized again and they may need to go back on. And this is just the natural history of how things work. It's not a failure on their part and it's not a failure on your part. We found the right medication at that time and then, another really big thing happened and they needed some more support while they built up more skills in psychotherapy. Next slide. And there we go. So that's it. And so these are all the references. And so I think we probably have lots of questions. Yeah.
Yes, we do. Lots of questions have been coming in. One question had to do with monitoring for somebody who is doing well at a dose, right? So how often do you follow up a stable patient in the office?
Yeah, it's a great question. And again, I'm gonna say you are the expert here. Your clinical judgment and what you know of this patient trumps everything. Maybe they have bad times around Christmas time and you say, oh, I better see them. I would say that I tend towards trying to see people, when they're at a stable dose, um, every 1 to 2 months. But caveat here, that I also practice in a slightly different situation, right? And so you may say, okay, well, maybe we don't need to check in person, but maybe it's a quick phone call or a quick visit. And maybe I have parents. This is a kid with parents who can really keep track of things. And so maybe you space it out to every 3 months. And so I would say that there's no hard and fast rule. Preference is like every 1 to 2 months, but if there's a kid who's just really doing well, I mean, I've had lots of kids who I don't see for 3 months at a time because they're on a stable dose. We're not changing anything. If changes are happening, I would say every month is ideal.
Baseline labs that you would consider or ongoing lab monitoring?
Yeah, that's a good question. I always do a baseline, just like regular CBC, BMP. Is it changing my prescribing practice? Not necessarily. Um, I don't necessarily routinely sort of check on labs other than sort of annually, unless there's something strange going on. One case in particular that comes to mind is a kid who actually did have nosebleeds. And we weren't sure. I thought maybe it was sort of platelet dysfunction, and we checked his platelets, and they were a little bit on the low side. The nosebleeds weren't out of control. And so we just said, okay, you know what, let's just do like a Q3 month like check. And if the nosebleeds get worse, we'll kind of check in. And so I would say that there's nothing hard and fast that you need to be checking. Annual labs, I think, are great. But if something presents itself in the course of treatment, you might sort of think about altering that schedule of monitoring.
So there are no standard labs to get at baseline, no standard labs to check. It's just if you're seeing some possible side effects or symptoms.
Yeah.
Okay.
Remember, these are really low risk,
Yeah.
low risk medications and for the most part easy to start.
Mhm. Also, at some point, should we consider tapering the dose down when the symptoms are well controlled?
Right. So that's where that sort of piece comes in, where we think about that maintenance phase. And again, 1 year of remission or near remission is really where I'm keeping everything the same. I'm not rocking the boat. I'm making sure that that person has all of their behavioral supports in place. And then after that year, we consider, if they're doing well and they're in a good place, we consider removing the dose altogether and seeing how they're doing, right? In my mind, at that point, if they're in a good place and family life is stable and things are going okay, then why not give them a trial off if everybody feels comfortable? And some people say, you know what, this is working for me, and I don't want to go back to that. And I think that that's a fair choice too.
Is there a tapering schedule you'd recommend as they're coming down?
So that again is the art rather than the science.
Yes.
I think a good rule of thumb is, if you went up by 5 or 10 milligrams every couple of months, you could sort of consider going back down every, 3-ish weeks, 3 to 4 weeks in the same way. Again, if someone wants to get off in a quicker way, give us a call. We're happy to think through a little bit more deeply. But, I think always easy to go down the way you went up.
How about for teens who are on birth control? Any specific points to keep in mind? The interaction between OCPs and SSRIs?
Yeah, I will say that it hasn't come up, and I haven't necessarily seen a reduced efficacy of oral contraceptives with concurrent use of SSRIs. So as far as I know, from what my reading and experience, I don't think there's any significant issues that we need to be thinking about. I don't necessarily choose Lexapro or Celexa, for example, just because somebody's on an OCP. I'm going to go for whatever's going to be most efficacious based on past response, family history, and side effect profile.
Wonderful. And I believe this may be from a family practice colleague, but is the frequency of the monitoring due to antidepressants having that black box warning in adolescents? Because typically for adults, they don't monitor this often.
Yeah. So I think at the beginning, yes, right, because that emergent suicidality is a real possibility. I think it's also compounded by the fact that adolescents' prefrontal cortex is not fully developed, and impulsivity is a really, really significant issue, right? So there's a specific there's like a very specific context here with adolescents where that impulsivity is something that I think even more about in terms of safety than my adult patients.
It's a very good point. Questions about dosages here. And one question is, I understand with OCD, dosages may go over kind of the usual recommended range. What medication dosages do you recommend for children with OCD and anxiety along with the depression?
Yes, so that is a good point, and that is a true statement that in some cases we do increase the Prozac, say above 80 milligrams, or we increase sertraline above the max of 200. And so I would say, it's okay to do that. I would recommend you give us a call so we can have a conversation about it. One of the things that comes up is, was there a benefit, as you were approaching the max dose? Did you get any kind of benefit at all? Because if you didn't see anything, it's probably not worth the potential risk to go further above the max dose if you didn't really see a difference there. And in that case, I might think about switching over. When we're talking about going above the max dose, though, it's not a huge amount. It's talking like 120 for Prozac, 250 for sertraline for OCD. But again, only if there was some kind of partial response in the normal dose range.
Or with Kath first. Okay. Another question had to do with for the slide that shows the number needed to treat to see suicidality. Is there a converse kind of set of numbers to say, well, how many kids with untreated major depressive disorder will have suicidality if they are started on meds, right? So you can compare the number needed to treat for good for number needed to harm.
For sure, yeah. No, that's a good point. I'm sure there is. I don't know what it is off the top of my head, but I recall somewhere that I think that the risk for, kind of adverse outcomes is greater if the kids are not treated for their depression. But I don't have an exact number, so I'm gonna pause. But we can look that up.
Dr. Schumacher may have an answer here. I believe she would like to answer. If you want to come on camera.
Yeah.
No, I don't. I was just recording that that he was answering it.
Okay, fantastic. All right, we may be able to come up with some numbers and come back to you because those numbers aren't immediately forthcoming. Can you speak to passive versus active suicidal ideation and how persistent passive SI affects the clinical sort of like judgment around depression severity classification and the
Yeah.
decisions around medication?
Yeah. So, we do make the distinction between passive and active SI. And obviously, active SI, you know, our warning bells are going off, and we're implementing a whole different set of strategies, right? Or a more significant set of strategies because we're more worried about acute safety. I do think that if you have persistent SI that's passive, that's really getting in the way of doing things. And again, I come back to that functional impairment piece. If it's something that sort of borders on obsessionality, where a kid can't think about anything else, then that sort of will push me further towards an SSRI treatment. Now, maybe you might have a kid, let's say, who has like moderate depression, who maybe has like very occasional intermittent passive SI, but they're functioning well. And that's that gray area. And it's clinical judgment time where you take into account like all the factors. And you might say, okay, well, maybe we can wait a little bit. Let's see what happens with that SI. And again, that collaboration piece where the parents and caregivers are monitoring is going to be helpful for us to know, okay, is this ramping up in a way now we need to sort of deploy our SSRIs in that case. But again, your sort of clinical judgment is permeating all of this.
With a QR code for those who may have to be going soon to clinic or to other things. And just a reminder, please use this QR code or the link if it can be placed into the chat to check in so you can get CME credit for the day. So, and I'm also seeing coming through the chat some recommendations about from Dr. Steinbushel about numbers needed to treat versus number needed to harm with SSRIs regarding suicidality, which is great. You can also see in the chat the direct link for claiming CME credit. Thank you so much about that. Continuing on with the next question, can you just comment on the maximum doses for teens for fluoxetine and sertraline?
Yeah, so max dose for Prozac is 80 and max dose for Zoloft is 200.
So there's normally the max doses. Thank you.
Yeah.
And there was a recommendation that when starting a medication, we can increase the dosages every 2 to 4 weeks, and that we should see a therapeutic effect, basically between 3 to 5 weeks. What counts as a therapeutic effect? Are we looking for full symptom relief or starting to see a positive effect? And at what point do you know, like, you need to switch tracks to a different medication altogether, as opposed to going up and up on the current one?
Yeah, so no, it's a great question. So 3 to 5 weeks, that's some kind of effect. And so this is where screening tools plus subjective information from both parent and child are going to be helpful in making a decision. So within 3 to 5 weeks, we're hoping to see some kind of effect. The PHQ-9 has moved slightly. The subjective experience of the patient and the family is that there's some improvement, but you haven't necessarily yet reached the adequate therapeutic dose. And so in that case, you might say, okay, we're going to keep going up. Now the question then becomes, well, when do I stop going up? And I think in that case, again, in the truest sort of most strict definition, right? Response is greater than 50% reduction, right, in the symptoms. But again, it's also subjective, right? Maybe family and parents and kids say, you know what, I feel much better. I just think this is a good dose. My PHQ-9 has gone down significantly. My function has improved, and you might consider holding at that dose. And it's possible that life may happen, and then you may have to change things slightly throughout the course of the treatment. But again, I think it's a mix of that hard and fast number plus the experience that you're getting from people.
Great. There was another question that came up about counseling, since it's so hard to get psychotherapy on any kind of timely basis, and new telehealth options becoming available. Do you have any particular recommendations for telehealth options for psychotherapy?
I think I'm going to defer because I think we have some of that on the website, and then also give us a call because we have somebody who's dedicated to helping us figure out what's right for your patient.
Yes, we do. I do want to underline that point. We do have some limited care coordination capacities available. So some of this information could be available through consultation. I'm not sure I'm seeing it on our website, but if we have a list that can be shared, that can be posted along with the recording for this lecture. Okay, so another question came. You mentioned we can call CAP in regards to tapering recommendations. What is the CAP phone number? The CAP phone number is 1-800-253-2103. That's 1-800-253-2103. And you can also go to our website, cap.ucsf.edu. That number is right there. And there's even a form that you could use to click on it and like put in your name and a callback time. And that's an easy way to place a consult. Great. And thank you, May, for putting those in. If you're having some technical issues with the QR code, we will try to follow up with you individually. So please do let us know if you're having trouble checking in using the QR code or the link that have been provided. A couple of very quick announcements before we close this off is that we will have our next webinar on basically a month from the date, Thursday, November 9th at noon. It will be on autism spectrum disorders. We hope to see you there. Thank you so much for all of you who came today and for all of you engaged. Thank you so much to Dr. Rampersaud for your great lecture and to Dr. Schumacher for helping to answer questions. And we hope to see you next month.